I'm presenting on the interoperability. Let me just go. So I'm presenting on lessons learned from interoperability architecture implementation in Malawi. This is work that we started as a country in 2016, and since that time, we have made some progress, and also we have learned some things that that we would like to share. First, for those who need more information on what interoperability is, this is the capability that is given to software systems so that they are able to share information with each other. So I think that's the key issue there. So interoperability describes the extent to which systems and devices can exchange and interpret shared data. So I think that's the architecture that we have been building in Malawi to enable that. In terms of lessons, I think I'll go straight to that. So in terms of lessons, I think the first lesson that we got was to be able to understand what is in the ecosystem. I think the screen that you are looking at, this is the a documentation of the systems that we managed to find in our ecosystem, and this is assessment that happened in 2015, leading to the work on the interoperability. We were also surprised with some of the systems and platforms that we found because some of them we had not heard about them. But the key thing about this understanding of the ecosystem is also, if you know what systems you have in your environment, you can also go a step further and understand how ready those systems are in terms of interoperability. So I think this was an eye opener for us because we noticed that some systems it would be difficult to include in the interoperability ecosystem, and we had to devise ways of making sure that those are part of the interoperability architecture. So I think that is the first lesson. The second one is the need to understand the gaps. So I think referring to the presentation on standards and the that was presented by Adane. So if you understand your ecosystem and you also understand what is supposed to be there, it is possible for you to look at the gaps that are available so that you can build on what is existing and make sure that you only add to address the gaps that you have. So you can see from us, when we did the assessment in 2017, 2015, we already noted that key components like the client registry was already available. And also the HMIs was also available, collecting a lot of health information. But you can see in the blood that there were a number of components that were not there, like the terminology service was not there. However, we had other components that were there but not completed. For example, the health worker registry, it was there. So I think this gave us the understanding of how much work we need to do in order to implement our interoperability architecture. I think this is a good lesson for us also to be able to understand the problem we are trying to address, and in course trying to understand the solution. I think what you see are three neighbors, which you can take as three systems, three platforms. So if the neighbor has to visit their neighbors, should they construct a road for every neighbor that they want to visit? The answer is no, that is not efficient. And you can actually, in terms of thinking through the solution, see that there's a better way of trying to address that problem. If we have one road, it can be shared by everyone, as long as we're able to construct that road properly. So I think in interoperability, it's good to understand that. I said we started this in 2015, 2016. We had pressure at that time to connect systems individually. People wanted to share data, partners wanted to share data, and the quick solution was to connect each system directly to each other. And by understanding our vision and the solution that we wanted to put in place, we managed to manage that process properly so that everyone understands that connecting directly is a quick solution, but it is not the best solution. So we took that through until we had our architecture developed and ready for use by the different systems. So I think in terms of understanding the need, the solution, we also looked at, in trying to convince everyone, we looked at best practices that everyone has thought through and could be more applicable to our environment. So in that case, we used very much the OpenHIE architecture, interoperability architecture, and also in the end we built our platform based around the OpenHIE interoperability architecture. So I think the key thing is to be able to understand where you are and what you need, but most importantly, the end result. If we have so many systems like we had, and we want to interconnect them, and the approach that we want to use to interconnect them, we should be able to also communicate in that design where we want to get to. So I think what you see is the same interoperability architecture, but reflected in a different way. And I think the key component here is looking at our health system. What systems in this architecture will fit for interoperability at the national, at the district, at the facility, and at the community level? And we're able to do that, and also to look at the key components that are needed for us to be able to achieve that. So you can see that the same solution has been recast here to show everyone what our end goal should look like. So I think that is for lesson 4. I think some of the practical things or key areas that where we learned, I think lesson 5 is key in that. So putting up an interoperability architecture is a complex process. And when we started in 2015, not many people had implemented this like at national level. Because our implementation is at national level, so we are interoperating national level systems. The key challenges that we had at that time was that it's a new concept. When we explain to people, we have to explain in more detail for them to understand and to appreciate that we cannot connect systems one-to-one now. We have to wait for this architecture to be in place. But we learned other things along the way. This being a new area, we also need new skills and the capacities to be able for us to implement such a complex architecture. So we were learning on the job. At least now we have the skills. We can share one or two in terms of our understanding. But this is key. When you are implementing such a complex framework, it means we need the skills and the capacities to be able to do that. And by the way, we have engineers, we have the IT personnel, the programmers, but they just need to understand that for you to implement interoperability, these are the key areas and also the tools that are needed for that, for them to have experience in that. So, yeah. I think the question 6 is what also I think Adani covered. When you are doing the interoperability, they are different components. I think they are referred to as standards. I'll just give example, like the Master Health Facility Registry. It's a system on its own. It has its own governance processes. How do you update the facility registry? Who approves that updating? So it means for each standard that you have in the interoperability framework, there is need for you to have the standards and the guidelines of how each one can operate, so that your full picture of an interoperability architecture is able to be functional. Otherwise, in that environment, if the master health facility registry is not up to date, people will stop using it. So you have an architecture, but that is not functional because there are some gaps in how it can be used. So I think the issue of standards and guidelines is very important when you are implementing an interoperability architecture. The other lesson is that so it's a complex process. There's no way you can fast track it. Maybe you can, but even after fast tracking, it will still take time for you to have a functional interoperability architecture, especially when you intend to do this at national level. Because all the standards have to be in place, the key ones, the key components have to be in place and for you to start using that architecture. So it is a slow process, and we should be able to communicate that from the beginning. That we are starting this to come up with something good, but it is going to take time. So you can also prioritize, like you don't have to have all the key components or standards available for you to start using the architecture that you have. You can start with some key components, and then you can also be building on that, since it is a slow process that takes time. So I think to us is just to show you, like after all the work that we have done to implement our interoperability architecture, it is functional. We have platforms now that are connecting to each other through the interoperability architecture. And now it is open, like we can connect as many systems as we can, since it is scalable now, unlike if we had to connect systems one-to-one. So, but even after that work, you notice that we still have gaps. We have made progress, but we still have gaps. What I'm showing you is the result of an interoperability maturity model assessment based on the tool that is there, I think through OpenHIE. That tool has the three main categories, domains: the leadership and governance, human resources, and technology. And within leadership and governance, there are key components there. And also within human resources, there are key components there. And also within technology, there are key components there. And you can see the scores that we have, 1 being poor and the 5 being the best. You can see we have scored as much as 4 in some of these, but you also notice that we have a lot of ones and twos, meaning that we have a long way to go in order to have a complete interoperability architecture. But the key thing is that we have made progress, and we are making good progress. Hopefully in the next few years or so, we'll have a complete architecture. So at that, I will stop, and thank you everyone for your attention. Thank you.
Thank you very much for this overview on what is happening and what you have been doing in terms of interoperability in Malawi. We have right now no specific questions on that topic, so let's continue with the next presentation, which is on the DHIS2 District Health Information System based AMR antimicrobial resistance surveillance in Ethiopia. So I give the floor to you, Esayas Kebede Gudina. We see your presentation. We're not hearing you right now. You will need to unmute.
Yeah, I was not able to unmute. I'm sorry for that.
Yeah, no problem. We
Thank
hear
you
you
very
now.
much. Yeah, I'm Esayas from Jimma in Southwest Ethiopia, and I hope you know my colleagues already. So I'm sharing you the experience from our side on DHIS2 based antimicrobial resistance surveillance system. In fact, I am presenting.
Yeah, sorry to interrupt. If you can try to show the full presentation. We're seeing the slides on the side as well.
Yeah. How about now?
Still, yeah, it's still showing the sort of PowerPoint window. If you use that one, that's okay.
Yeah.
Thank you.
Yeah. So I am presenting our experience only, but this is a part of a network project known as acronym COMBAT AMR, which means Comprehensive Multi-Center Bioinformatics Activity to tackle antimicrobial resistance. We have 6 partner sites in Africa, 2 in Ethiopia. One is Jimma, another Asala, and we have another in Kenya at the Kenyatta National Hospital. We have also one in Uganda at Krudu National Referral Hospital, and then in Butare in Rwanda, Butare Teaching Hospital, and then we have also in Ghana a partner at Komfo Anoki Teaching Hospital in Kumasi. So we started this project with our German partners that was supported by GIZ. We have 6 partners in Germany paired with all the 6 partner sites. So when we started this project, it was initiated through the problem we faced in antimicrobial resistance in the world and in particular in Africa, where the result communication system for microbiology is a big challenge. And we follow a traditional system of lab specimen being transported by either healthcare worker, patient, or family member, and request sent through paper to the laboratory. A big problem which is still existing is how to get the result back to the physician, where the treatment decision and revision of antibiotics should be put in place as soon as possible so that effective treatment is administered to the patients. But in reality, most of the time the results are lost, and if at all they return back to the treating physician, they are delayed by hours, in most of the cases by days and even weeks, which means it will not have significant effect on healthcare outcome, and perpetuating antimicrobial resistance and extra costs to the patient, because patients need more antibiotics, more hospital days, and additional diagnostic tests because the initial lab result has been lost. So we wanted to change this traditional paper-based system using a digital approach so that we have data easily shared between all the diagnostics and treatment sites. So we wanted to use a system that will help enter information into the database at the laboratory, and the specimen is sent through patient ID or QR code by the physicians to the laboratory, and the result reaches treating physician at the bedside for decision, along with information to guide a treatment of a patient. And most importantly, to have data where it can be analyzed and used for disease surveillance as well as a policy level. So for that, we want the system that is open source and free, is flexible and being used in partner countries, and can easily be integrated with the existing system, as the earlier presenters said, because most common problem in African setting is where the electronic medical recording system was started, is that systems do not work well with each other. So for that, we have a good platform in place, the DHIS2, which is being used in many African countries, including these partner countries, for this partnership. So from this platform, we wanted to create a system where the result, the specimen is directly sent, documented and sent to the lab, and the result reached back to the treating physician for decision as soon as it is available. And then the system that also creates a database for antimicrobial resistant surveillance and treatment guideline, and of course also to feed to the global database for to combat antimicrobial resistance, and of course also for the partner institutions for this research network. So we wanted to create a system that links this platform to the national reporting for antimicrobial resistance that as called the HUNIT for AMR surveillance in each country, and then to have a database in which case we share information between these countries. So for that, we had a workshop in Asala in just before the COVID crisis took over in February 2020 in Ethiopia, in Asala, where all the partner sites from Germany and Ethiopia and Africa gathered. And we contracted out this to the HISP India, because HISP India had the experience of customizing the DHIS2 for antimicrobial resistance. Otherwise, most African countries do not use the DHIS2 for specific services. It's only used for aggregated reporting to the ministry. And then, of course, we used also the HISP Ethiopia node to support us in developing this platform. So the features of this platform are user logs in into these tools through the AMR surveillance application, which is customized from the DHIS2. A user selected the assigned hospital and registered the patient by entering the demographics like we do for any other electronic medical recording system. And then we put all the details, including socio-demographic. And then in the laboratory, we have all the platform to enter if there is a growth of organism, if there is no growth, if there is growth, what the type of the organism, and when the susceptibility test is done, and then the specific test for each organisms. And then there is a system that will auto-detect the resistance, intermediate or susceptibility pattern of organism based on the disk diffusion if the hospital uses, or the minimal inhibition concentration, MIC. So this is the feature for the server. At each hospital, we plan to have the mobile app, and then the web application as well. And then there is a lab interface where that laboratory data is entered, and then the clinical interface where a clinician accesses the result and also adds clinical data, and then the microbiologist for aggregate analysis of the data. And then we have also the anonymized data for the researchers, for the microbiologists, and reports to the national and the global for decision making. So this is what the platform looks like. It's more or less the same as the the DHIS2 that is used for aggregate reporting, but this is a customized one for AMR surveillance system. And then we have also the Android version where you can put on your Android and then use for accessing. In fact, you cannot enter most of the data on the mobile application because it is still under development for entering data, but now we can access the lab results through the Android application. So this is what it looks like when you enter the data at the lab site. You can put, I removed the patient name, you can put the medical registration number, the age of a patient. We know there's a problem in Africa to put the age of the date of birth, so we put the age, and the system auto makes guesses the age of, the date of birth of a patient. And we have the name of patient, sex, and then the hospital. This is important because in the end, we want to analyze data for decision making at the policy level and at the ministry level. Then this is the first part where we put the demographic data, and then we have also the laboratory platform where you put the type of a specimen, type of test performed, whether there is growth or not. So when the result is, if there is a growth, you can put the susceptibility pattern, either using the disk diffusion or the minimum inhibition concentration for each antibiotic. So in most African settings, we only use now the disk diffusion. We put for each antibiotic tested, and once we make the test, and unfortunately you don't see it, I think the color is not good enough. So if it is red, it means it is resistant. If it is yellow, it is intermediate, and then if it is green, it is susceptible. So the lab personnel is not expected to make judgment on that. The system auto-detects this when you put the disk diffusion, the disk size, and then it makes this is susceptible or intermediate or resistant. And the system also assigns ICD-10 for each organism, for each antibiotics, once you detect all the values in it. This is important for reporting to the national level. And another important feature of this system is that when a physician accesses the result, it will give feedback to the lab that the report has been accessed. For instance, now I accessed these two results, and it says you have a market for follow-up, which means that the lab personnel will get the information that this has been used for treatment decision. If not, the physician will put a feedback in the system if there is a problem with the result or if they want to do it again. So this system also has a dashboard for analysis, and there is a specific patient data which is aggregated by pushing the required variables in aggregated data elements. So it is anonymized. Anyone can access it, but usually we preserve this for researchers or for people involved in the hospital leadership. We have also dashboards designed for and that will present for each isolates and resistance patterns, also in terms of the units of hospital, and if it is for separate institutions, for each institution it will be analyzed separately. So this is what it looks like. For instance, organism group-wise isolation rate. So this is for each hospital, for instance, for this organism at 2 hospitals, and then there is a total for each. And then we have also the same. This is in terms of a percentage. And you can also see in terms of the susceptibility pattern, green being susceptible in this case. So you can use this analysis for antimicrobial stewardship, monthly reporting to physicians in respective hospitals. So in summary, we found this system, the DHIS2 based antimicrobial resistance surveillance system is easily developed, can easily be developed from the generic DHIS2 without so much problem. It can easily be implemented and integrated to the existing system. It is cost effective, applicable for all services in countries, and we found it very important means to combat antimicrobial resistance. This is all about my presentation. Thank you.
Thank you. Thank you very much, Esayas, for this overview, and also happy to see that this is based also on or with collaboration in collaboration with partners in Europe. That is, of course, also part of what we're looking at within the project. Over now to Chipo, Kanjo in Malawi, to tell us more about their iCommunity health information system. Okay, Chipo,
Hello, good afternoon. Can you see my screen?
Yes, perfect.
Okay, thank you. Chipo Kanjo, working with University of Malawi and a member of HIS Malawi. I'll be presenting on integrated community health information system, which we briefly call ICHIS. Okay, it all started with the National Community Health Strategy, the 2017-2022 strategy for community health, which emphasizes on quality integrated community health services that are affordable, culturally acceptable, scientifically appropriate, and also accessible to every household. And ICT was seen to be one of the most effective way of achieving this. And as this is it par with what had happened with the health facility level, where since early 2000, there've been talk of coming up with some integrated EMRs for the nation, but this far it hasn't really materialized. So the community level thought of doing things differently, starting from start with some integration. Now, what exactly is this integrated community health information system? It's an initiative which provides quality, aiming at providing quality, accessible, affordable, and context-aware community health care through integrated and configurable digital platform, as was stipulated in the strategy. And the reason why ICHIS came into being was to support improved performance and higher quality service provision, because it would enable standardized guidance on clinical decision-making. And this is community level, where the community workers at that level, they don't get that much training from where it goes. So as they work along the way, they also need some form of support. And in the absence of a system, then chances are different workers would be coming up with different decisions, but this enables standardized guidance on clinical decision-making. It also allows to manage longitudinal health data records. Other than supporting the performance, it also promotes a harmonized community health information system with a multi-directional flow of data and knowledge. And this is also one of the issues over the years which have been problematic in terms of feedback. There's always been complaint of information going upwards and never coming back. But with such a system, it promotes harmonized community health information system with much directional flow of data and knowledge. And we, like was mentioned in the presentation by Salim, that the aim of Digital Atlas is to read siloed, inflexible, and uncoordinated systems. Here we also able to do away with siloed solutions, because for the nation, we're having one integrated community health information system. It also does provide multi-level access to data, and also provides patient-level data analytics, which is very, very important. They're able to see how exactly things are going on, even at the lowest level, at community level, and being able to, from the dashboards, being able to make sense of the analytics, and in some ways decisions at that level. It also does enhance system interoperability because we're talking of one system. Later, you'll see that we're also using the HIS2, which is also used at national level, and that also does enhance system interoperability. And with the integrated community health system, we're able to achieve, because of the way it's been designed and the devices which are being used, we're able to provide ubiquitous access, because you can access it via a laptop device, you can access it via web access on smartphones, tablets, laptops, desktop computers, or you can use smartphones. You're also able to use mobile access via Android-enabled smartphones and tablets. One is able to work or support for work offline, and at some point you're able to also pass on messages via SMS. So that way it does allow for ubiquitous access, not in the context where in some cases connectivity is quite intermittent, and this allows for the community workers across to be able to access and work with the system. In terms of the architecture for ICHIS, we have a high-level module architecture. We have the system with different registers at different levels: household register, community register, personal register. This just mimics what we have in the manual system, where we have household registers, community registers, and also personal registers. Household register, mostly it's about the environmental health issues. Community register looks at the community-based childcare center, the sputum collection, secondary schools, village details, primary school, and then personal register has also got different modules in there: population, family planning, newborn care, and the other health programs within that particular register, so that each person, each patient can be able to access the different health programs at community level. In terms of the system, a few screenshots here, where you go to the home screen and you can pick whichever option you want. Is it community register you're looking for, household, or annual reports, semi-annual reports, quarterly reports, or personal register? And that takes you into further details of that particular option you go into. And mostly the community workers will be using the tablets or smartphones. For technology, this system is, like I mentioned earlier, is built on DHIS2 platform. Both the tracker and then they aggregate. For one of the issues which I have to mention for this system, because it started with strategy and then stakeholders came together and came up with a way of solving the issue of implementing a system at community level, and they decided to go for integrated community health system. This is one of those systems within the country which have got political will from the highest level. And as you can see from the picture, is our president, who was also attending the national launch for the Community Health Day, where this particular system was also being showcased. And having developed the initial modules for the systems, we did a pre-test following the user involvement, user participation, user-centeredness, and ensuring that the users of the system eventually owns the system. We did a pre-test of the system in one of the districts in the southern part of Malawi, which was quite successful, quite interactive, and we got a lot of feedback to improve on the system. Further to that, we also started doing the implementation of the system, again, in one of the districts. And this would start with overview of the system, briefing the participants on the different registers and how to capture data, how to come up with reports and so on. And then following that, we go to the field and then supervise them. First, we leave them to do it on their own, and then we supervise them, and then they give us feedback. This is another of the Kasungu field implementation. And for the future outlook of the system, we're planning to continue collaboration with Ministry of Health, who are the owner of the system, and to develop the remaining modules, which, and from the feedback we got, they've actually prioritized which modules should go first. If we were to do it on our own, we would have done it differently, but they know exactly which ones are of higher priority. And there is also increased partnership with development partners. We started with a few, but now more and more partners are being interested to get on board. That's for funding. And that also reminds me Salim's presentation, where he had categorized government as the owners, investors, and implementers. So we having more of the investors being interested. We also would continue with capacity development for local systems development and support, and continued partnership for interoperability. And this is so because it's not just us, University of Malawi, offering technical support. We're also working with other partners to ensure that there's more capacity development and more partnership for interoperability. In terms of leadership for the current efforts, then we have the Ministry of Health as the owners of the system, in partnership with investors like UNICEF and Last Mile Health, and there are more on the list who are yet to commit themselves. And us as University of Malawi Computer Science Department, we're providing the technical support. And I end my presentation here. Thank you very much.
Thank you very much, Chipo, for this look behind the scenes, I would say, of your projects and initiatives with the Community Health Information System, looking and providing some insights into the architecture, some of the technical aspects, but also how you implemented this in the field and were collaborating with the stakeholders on the ground, let's say. Also talking about the partnerships that were and are behind this and the funding and so on. So again, it brings together quite nicely a lot of the topics and factors that we are also looking at and considering within the entire Better eHealth project. So thank you very much for that. And then we move on to the last presentation in this session, which will give us a look at eHealth projects at the Trust Hospital in Ghana. So Kenneth, Azumah, the floor is yours.
Right. Thank you, Frederick. Can you hear me?
Yes, loud and clear.
Okay. All right. So this is just an overview of what Trust Hospital is doing. And I'll show you where we've come from and what we have done so far, and then how this eHealth project, Better eHealth, program is helping us to align our strategies for better interoperability. So the outline, I'll show who we are, our locations in the capital of the country, the services, the infrastructure, and how all these culminate into Better eHealth access. It started as a non-profit facility and mainly to cater to the Social Security and National Insurance Trust, staff. But as of 2010, they started hiving off because more of the public were patronizing the facility. So we needed to operate as a full-fledged hospital. So a limited liability company was formed, and it took about 2 years to completely hive off. Today, we operate 3 hospitals and 6 satellite clinics, all in the capital. The range of services is comparable to that of a regional hospital, and there's a monthly attendance of about 21,000. We have 120 plus GPs and specialists, and a staff strength of 600 plus. These are our locations in the capital. As you can see, there are clinics around, a group of centrally located hospitals. So the satellite clinics are primary points of care, which serve as feeders into the main hospitals. It's a very old hospital, so they had initially started with folders, and even when you give a tall story building, it's going to fill it up with folders. So the efforts were made to actually go electronic very early on. But the software that was being used had a licensing problem in that as you increase the number of users, you have to also pay for that. And for a rapidly expanding hospital, this was untenable. So the decision was made to build one from scratch with a local vendor. As a private company, you had to focus on how to generate your revenue first in order to sustain the business. So we started the whole thing as a billing system, and then looking at the spread of the clinics and so on, this had to operate over a wide area network. And then later on, for the other points of care, like the pharmacy, the investigations areas, those were added on. So when it started as a billing system, there were capturing sheets that were sent to a centralized location where clerks entered the information into the system. And then later on, points of care started, instead of writing on the sheets, they started capturing directly into the system. So looking at a place like lab, as you use your reagents and so on, you have to go to the stores to be able to replenish. So looking at the decentralized way by which everything was operating, we needed a system to also support that. And then in 2018, the doctors and the inpatient points of care also had to be rolled on. So it had to be built module by module because it's from scratch, and then you test thoroughly and keep moving. And then now what do we do with the old physical folders? We had to digitize them and load them into the system so doctors could have the history as well. And now you have your system running. How do you get the patients to also see some bit of their clinical or health information? So this year we released a beta version of a mobile app towards that end. This was a training. Initially, there were a lot of resistance, but we had to gradually overcome that. This is a session of training that was held. And when the computers were being procured, we just brought them all to a location and used it as a room for training. And then after that, they were all dispersed to the points where they'll be used for capturing. So this is how we also approached it. Looking at our range of services is what it entails. The ones in orange are ones that we have been managed to use telemedicine to, actually facilitate those services. Telemedicine started intensively in March 2020. That's at the height of COVID in Ghana, when people were scared to come into the hospital. So we offered this option. And so far, it's been okay, and it's still growing. These are the statistics for the telemedicine. Initially there were GP reviews and consultations mainly. It wasn't that much, but this year so far, and as at the end of October, we've had some specialists rolling on. And then pharmacy that you see here are refills, people who just call the pharmacy and say, I don't want to come, can you have my medication delivered? So these are how we have also been able to engage our clients. With a mobile app and all the other facilities that support client interfacing with us, they can make an appointment. All of it goes into our central health information system. When there's telemedicine consultation from wherever the physician is, he can also log into the health information system. And then via the mobile app, the patient is able to see some of the information like prescriptions, lab results, and so on. And then through this mobile app, you can also call or locate the nearest facility so that you can have your service rendered. Now, the digitization did not only affect the health aspects, the administration was also taken care of. We are still in the process. We seek to make it stronger and cover all the various points. One key feature is because of our distributed nature, we had to run the stores in sections. So for example, one clinic has a store, but if you have excess of something, the next facility should be able to see it and make a request. So there are inter-store transfers all through the wide area network. There's also a leave management system that runs on the network. Procurement, the ones in orange are yet to be implemented, and we hope to do that in the coming year. By virtue of the wide area network, we are able to do VoIP calls, and then systems integration. We are looking to integrating with the DHIS. And these are some of the plans that we have. We are working with the Ghana Health Service towards this end. And participating in these e-health conferences and programs helps us to better align our systems for interoperability, future interoperability, make sure that we comply with the standards and so on. So our overall strategy, which we keep fine-tuning so far from our participations and what has been presented so far, is first to look at the architecture. which Mr. Kwashi talks about most. So we look at most of the things that he does, and then we try to make sure that we have a very sound architecture in place. We also look at the governance aspects of it, where we make sure that we comply with national policies. We take into consideration the client needs. And then we also, because we are private, we also need to look at our business strategy. And for monitoring, of course, the technology keeps changing. We need to make sure that we are looking at safety, we are looking at compliance, and then we are making sure that it can be broadly accessible. And then, of course, by virtue of conferences like this, we can do more collaboration. Because the system is home-built in collaboration with a local vendor, there is more room for building custom interoperability features into all of this, all to inure to the benefit of the patient. So that's briefly what we have done as a hospital. Thank you very much, Frederick.
Thank you,